Hello, professionals. This is Dr. Saad, and as you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. Today's video is the second part of clinical aspect of endocrine system, where we'll talk about menstrual cycle disorder. So, so first complication is premenstrual syndrome, and first of all, we will talk about its clinical manifestation. Patient respond following affective and somatic symptom during 5 days before menses. That is these symptoms include from the affective side is the depression, anger outburst, irritability, anxiety, confusion, and social withdrawal. And from the side of somatic symptoms are breast tenderness, abdominal bloating, headache, swelling of extremities. These symptoms will, you can say, disappear at the onset or shortly after menstruation begin. This is the clinical manifestation of premenstrual syndrome. So next is the its management strategies. It is divided into two main types, that is the non-pharmacological approach and pharmacological approach. From non-pharmacological approach, it is recommended to use good diet including restriction of caffeine, alcohol, and avoid smoking and doing exercise. Include prunes, figs, celery, cucumber, parsley's food, and those food which contain high vitamin K, including banana, orange, dry fruit, nuts, soya beans, and tomatoes in diet. It will be helpful for this situation. Hypoglycemia may also involve, so eating small protein-rich meal more frequently may help. And the use of pyridoxine, that is also known as vitamin B6, 50 mg 2 times per day before meal or 100 mg after breakfast. This should be start 3 days before the symptom begin. In a patient of premenstrual syndrome, this should be start 3 days before. Similarly, use of calcium supplement with the help of our calcium supplement, vitamin D supplement, and magnesium supplements, and evening primrose oil, or include non-pharmacological approach for the management of premenstrual syndrome. Next is the pharmacological management of this disorder. Just keep in your mind that progestogens are no longer recommended because it causes weight gain, nausea, breast discomfort, and breakthrough bleedings. That's why progestogens are no longer recommended in management of premenstrual syndrome. Combination oral contraceptives are often prescribed. These prevent the ovulation but also have a risk of venous thrombosis. So risk-benefit ratio has to be assessed prior to recommend this. Example of combination oral contraceptive which is used for this include ethinyl estradiol with the combination of drospirenone. Selective serotonin uptake inhibitors are effective at first-line therapy for severe premenstrual syndrome, and side effect at lower dose are generally acceptable. That's why it is recommended as a first line for management of anxiety that is major visible in premenstrual syndrome. Example include from the SSRI are fluvoxetine, sertraline, citalopram, fluvoxamine, and paroxetine. Bromocriptine is useful in breast tenderness and fluid retention and mood changes. Similarly, we use progesterone. We use prostaglandin sense inhibitors. It improves in tension, irritability, depression, headache, and general aches. So for prostaglandin inhibitor examples are mefenamic acid. Its starting dose is to 50 mg 12 days before symptom begin, or you can say before menses start, or you can increase its dose to 500 mg 3 times per day 9 days before the periods, and continue until the third or fourth day, of period. So by use of these pharmacological and non-pharmacological strategies, we manage premenstrual syndrome. So this was just roadmap from the clinical aspect of management of premenstrual syndrome that comes under the menstrual cycle disorder condition. Second condition that comes under this topic, that is the menstrual cycle disorder, is the dysmenorrhea. The pattern would be same. Again, we will talk about the primary dysmenorrhea and secondary dysmenorrhea, its signs and symptoms. As long as primary dysmenorrhea is concerned, it shows lower abdominal pain, radiating into the thighs and back, extended duration of menstrual flow, and pain can be more severe when flow is light. Weight, length of menstruation, and frequency of physical exercise do not affect the dysmenorrhea. So, weight, length, and frequency of physical activity do not affect the dysmenorrhea. That's independent factor. So, major sign is its pain and its pattern and its flow pain that can be severe when flow is light. These are the clinical manifestation from the side of primary dysmenorrhea. Secondary dysmenorrhea. It begins at the age of 30 to 40 and usually occur at the consequence of other pelvic pathophysiologies such as endometriosis or pelvic inflammatory diseases, or due to intrauterine contraceptive may also exacerbate the menstruation pain because of localized inflammation. So intrauterine devices and endometriosis and pelvic inflammation, that is either linked with the intrauterine devices or also linked with it, or localized inflammation. So fewer pregnancies is one of the contributing factor for the prevalence of dysmenorrhea. Women who diet contain more omega-3 fatty acid tends to suffer less. So this was all about clinical manifestation of dysmenorrhea. Now we'll see what its management strategies. NSAIDs. NSAIDs are more effective than that of paracetamol, and mefenamic acid is also option. Leukotriene receptor antagonist, example is montelukast, reduces the NSAID usage and more effective in women without endometriosis. Combination oral contraceptives are also recommended, but not all women are candidate for combination oral contraceptives because estrogen has a contraindication of high blood pressure, obesity, and family history of thromboembolism. Antimicrobial therapy is indicated especially for PID, and endometriosis treatment is required if it is one of the underlying causes. Vitamin B6 is recommended as a supplement in the dose of 100 mg once daily. So it was the management strategies for the dysmenorrhea. Next complication that comes under the menstrual cycle disorders are heavy menstrual bleeding. For it is required endometrial biopsies is an essential in women who were older than 40-year-old. Causes of heavy menstrual bleeding. Almost 60% causes of heavy menstrual bleeding are unknown. 30% other causes that include urine and ovarian tumor and endometriosis and pelvic inflammatory diseases and intrauterine contraceptive devices and early pregnancy complications. And less than 5% situation which holds are hypothyroidism and platelet problem and clotting abnormalities. Iron deficiency causes anemia, which is in the reproductive age. So for heavy menstrual bleeding, pelvic ultrasound is required for examination prior to initiate or draw therapeutic planning. It was all about the clinical manifestation of heavy menstrual bleeding. So next is the management strategies. We'll use selective estrogen receptor modulator. That example is the ormiloxifene. It is used in the dose of 60 mg twice weekly. And tranexamic acid reduces 50% of blood loss. Its dose is 1 gram 3 times per day, and start on the first day of menses up to 4 days, and stop if no benefit is appear after 3 cycles. So its starting dose is 1 gram 3 times per day and start at the first day of menses and up to 4 days, and stop if no benefit after 3 cycle is visible. It was all about tranexamic acid after selective estrogen receptor modulator. Combination oral contraceptives are recommended for 21 days to restore the cycle and avoid heavy menstrual bleeding. Progesterone only preparation is also useful. Danazol and GnRH analog antagonist and NSAIDs are recommended for its management strategies. Next complication, so it was all about the management of heavy menstrual bleeding, and the next complication is the endometriosis. Its clinical manifestation is more frequent or heavy bleeding and more likely to be suffer from endometriosis. This is one of the key line for clinical manifestation of endometriosis. More frequent and heavy periods. This is and more likely to be suffer from the endometriosis. Its management strategies, its surgery as a major part of its management strategies, it include laparoscopy. Its target is to restore the normal pelvic anatomy. Low dose of combination oral contraceptive that includes 20 to 30 mcg of ethinyl estradiol and danazole localized administration. Low dose, you can say 200 mg per day through a local administration by the use of intrauterine devices. Progesterone or medroxyprogesterone and low dose of estrogen and progesterone continuously, and intrauterine devices that release levonorgestrel, and through non-pharmacological approach, use of low sugar rice and potatoes and caffeine reduce or eliminate caffeine, low sugar, or use, or simply I would like to say that reduce or eliminate caffeine and use low sugar rice and potato, and similarly increase the omega 3 fatty acid and fixed seed oil for as an non-pharmacological management approach for the management of endometriosis. So it was all about today's video. I hope if you feel that our this effort is helpful for you, then please subscribe our channel and guide us so that we can improve according to your requirement. Thank you.